right? You think about a box in someone's home. What we're really going to, right? Because behind those boxes, right? So every box that you see technologically is a commodity, right? There's no magic to these boxes. If you look at our product, which is the Health Buddy, the appliance, a 12-year-old could go to, Fry's, the electronics store, could go to Fry's and basically build, except for the plastic casing, could build a Health Buddy in over a weekend with a soldering gun. So again, I'm not trivializing our boxes to an extent, right? They're FDA approved, and that's a lot of overhead there. But at the end of the day, those are commodities. What's really important, really, is the intelligence that resides in our platforms, our software platforms, our communications platforms, the platforms that move data from a patient in their home to a provider. And then also, so depending on your model, move content and other interactive content in what you're going to try to get from the patient or assess them for that day back to the patient. So it's moving stuff back and forth. And there are really important things there that live there, like analytics, right? So that you're not just getting data points that are going to overwhelm you, right? But you're actually getting actionable intelligence. So let's go to the next slide. So let's compare and contrast EMRs with telehealth/virtual care. So what do EMRs give you, right? We're talking about historical encounter data, right? So they tell you where the patient has been in terms of encounters with traditional clinical points, traditional clinical settings, right? Go to a doctor's office, record it in the EMR. Go to the hospital, record it in the EMR. Problem, of course, is that, and this is a huge problem, as we all know, right? You're in home care and you're trying to get a comprehensive look at your patient. How do you do that, right? Your Allscripts system, does it talk to your hospitals or the medical group's Epic system? Not yet. We talk about health information exchanges, but how many of you are in a community that has a health information exchange? Yeah, at this point it's kind of like the unicorn. We'll all believe it when we see it. So what you can think about telehealth expresses virtual care, again, kind of a Silicon Valley buzzword, is what those systems, those platforms are giving you, depending on their level of maturity and sophistication, is you get to know what's going on with the patient right now, right? And that's so intelligence that is current and actionable, depending on the telehealth companies or the virtual care companies model, is current and actionable for both providers and for activated patients.
The desktop unit that you saw in the Intel video, that's one way of doing it, but there's another way of doing it where you don't even see. All you have is the blood pressure cuff and the weight scale, and everything else is electronic and wireless and invisible. It's cheap. There are lots of inexpensive ways to do it. And you go to the hospital and you tell them that you're going to save them those readmissions within 30 days. Those readmissions within 30 days are killing the hospitals. You go and say, give your patient to me, it won't happen, I'll keep them out. And you're going to find the referrals are going to continue to grow to you. So I'm saying get over it because this is not a fancy, unique, exotic technology anymore. Medicare doesn't pay you for your stethoscopes, or your blood pressure cuffs, or your pulse ox, so why should they pay you for your home telehealth systems? The PPS margins, I know it's coming down, but in the last 10 years, they've been more generous than anybody's willing to admit. And you've got the money. You can afford to start small, buy 3 or 4 monitors in the next 6 months, buy 5 or 6 more, see how it works. Medicare's paying for it. And if they don't, go to your insurance companies. Tell them you're going to save them some money too. And they'll jump all over you. Walk to the insurance companies you've got contracts with and say, we would like to save you millions of dollars. They'll sit down and listen to you. And a lot of insurance companies are doing this, where they are paying for the systems. It's happening in spots around the country. They're actually paying for the devices, putting them in your agency so that you can use them with their patients.
Project. And if it was so demonstrations are like science experiments without a clear path to policy. Pilot programs do have a clear path to policy. I think this was a demonstration. It was called the Physician Group Practice Demonstration. 10 either multi-specialty medical groups or integrated delivery networks across the country. And they were basically given shared savings based on a formula that was both about financial performance monitored against, not against necessarily a control group, but against cost trend, and certain quality metrics. With the importance that it was a 5-year program, or it ended up being a 5-year program that's just ending now, started in 2005, with increasing importance put on the quality metrics. The reason I tell you this, okay, 4 of the sites succeeded wildly. 3 multi-specialty medical groups and 1 academic medical center, University of Michigan Health System. Other 6 didn't do so well because they were more hospital-based, and again, hospitals were sort of like, get this whole upside concept, but you know, this is going to decrease the demand for my main product, right? The reason I tell you this is the physician group practice demo was turned into policy as the accountable care organization. So that's where you get demonstration of savings, that it's possible through, and the